We call upon Dr. Sanchita Gupta. Is she here? Yeah, welcome. The topic is a clinical review of Miller-Fischer syndrome, a rare variant of Guillain-Barré syndrome.
Good morning, everyone. MFS is an autoimmune mediated peripheral neuropathy associated with anti-GQ1B neuronal antibodies. It's a monophasic self-resolving triad of ophthalmoplegia, ataxia, and areflexia, first described by Charles Miller-Fischer in 1956. It belongs to the GBS spectrum. It represents 1 to 7% of all the GBS cases worldwide. It has a higher prevalence in East Asia and 19 to 25% alone in Japan. Mean age of onset is around 35 to 45 years and with a male to female ratio of 2:1. It has a seasonal variation. It is an autoimmune mechanism triggered by molecular mimicry. Anti-GQ1B IgG antibodies are found to be positive in 85 to 90% of the cases. GQ1B ganglioside is expressed in the paranodal regions of the oculomotor, trochlea, abducens nerve, and the dorsal root ganglion of Mersal spindles, thereby explaining the triad. It has a common preceding infection, example, Campylobacter jejuni, influenza virus, CMV, EBV, and Haemophilus influenza. Why is MFS self-limiting? It is a transient immune-mediated pathophysiology. It is mediated by anti-GQ1B antibodies following an antecedent infection. The autoimmune attack is short-lived, halting once the antibody titers decline. The damage is mainly functional. It shows a nodoparanodopathy rather than a widespread axonal loss. This means conduction failure is caused by antibody binding at nodes or paranodes, not by permanent destruction. Since this is functional and reversible, normal conduction returns after immune resolution. It has a minimal or no axonal degeneration. Unlike axonal variants of GBS, MFS largely spares the axons, thereby the preserved axonal integrity allows rapid remyelination and recovery without major sequelae. In our case, a 37-year-old male presented with complaints of double vision and blurring of vision since past 3 days. His medical history was unremarkable. He had a history of difficulty in walking since 3 days. Patient gives history of abdominal pain along with diarrhea for 4 days, 2 weeks back, for which he took medication and was relieved. Clinical findings: his visual acuity was aided 6/9 in both eyes. Fundus examination and slit lamp examination were within normal limits. He had a 15-degree exotropia in the left eye and there was no abnormal head posture. Eyeball movements was restricted more in the left eye and more so in the superior quadrants. We can see here mainly the restriction is in the superior and the medial quadrants and more for the left eye. MRI brain with orbit was normal. CSF study shows albuminocytological dissociation. Serum anti-ganglioside antibody panel was ordered and serum anti-GQ1B IgG was positive. NCV study was suggestive of pure motor demyelinating polyradiculopathy with axon loss affecting bilateral lower limb more than bilateral upper limb. We have an MRI here which shows it was absolutely normal, thereby eliminating any chance of stroke or encephalitis. Management outcome: patient received 4 doses of injection IVIG, 34 gram IV OD for 4 days. Patient showed significant resolution of ophthalmoplegia and ataxia over 2 weeks. No residual neurological deficit at 2 months of follow-up. Summary: early recognition of the triad by ophthalmologists is crucial. Prompt antibody testing and initiation of IVIG optimized outcomes. Awareness of the benign, self-limiting nature prevents misdiagnosis and unnecessary intervention. Ultimately, timely ophthalmic suspicion can change the trajectory of this disease from a potentially alarming neuro-ophthalmic emergency to a condition with excellent recovery and minimal long-term sequelae.